Dear colleagues, ladies and gentlemen, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. My name is Nicolas from Mieghem and I'm standing here live in Paris at EuroPCR 2024 together with my good friend and colleague Joost. Joost, we're going to do part one of the wrap-up of the late-breaking clinical trials at EuroPCR. Where do we start?
Yeah, so welcome. We are here in Paris, EuroPCR 2024, a great edition, 12,000 attendees, 20% more than last year. So it's really a packed meeting, good vibe, and also some interesting trials that we want to discuss. So what we want to do is to kick off with two trials from our Chinese colleagues. One is the Career trial. It's a study on the diagnostic performance of fully automated computational CT-based FFR in the Career trial. Mm-hmm. So the Career trial is basically the validation of CT MuFR, which is the algorithm of Pulse Medical to identify physiological lesion significance based on CT imaging in patients with intermediate coronary artery lesions. So this trial enrolled a bit more than 200 patients finally that underwent a CT scan and subsequently a diagnostic coronary angiogram, including invasive FFR and core lab assessed MuFR, which is the angio-based FFR index of Pulse Medical. With that, the investigators were able to demonstrate an excellent diagnostic accuracy of CT MuFR of about 90% in patients that underwent these core lab assessed MuCT FFR. Diagnostic accuracy, as said, 89.6%, sensitivity specificity figures about 90%. So a little bit as anticipated, excellent results. But what was more interesting, or perhaps as interesting, were a couple of secondary analyses the investigators performed on the effect of semi-automated versus fully automated contour detection. And what happened is after you use the semi-automated process, which is basically what happens in most of the algorithms, as with HeartFlow, you needed about 9 minutes to do the assessment. Whereas you would use a fully automated assessment, you can bring down analysis time to merely 1.6 minutes. So that makes this technique readily available in actually basically each institution. So that's to me could be a game changer in the way we assess CT scans. The quality or the effect on the accuracy was merely 1.6%. So it actually you pay a little bit of a price in terms of diagnostic accuracy, but not that much. And that said, I think the technology is very promising.
And this is totally different from currently existing CT FFR systems.
Well, it's basically a technology that allows you to use computational fluid dynamics to computate pressure gradients across specific segments in a coronary artery. Well, in this case, no, you can use this software in any institution.
Interesting.
Yeah. Second from the same group was an analysis on regional wall strain. We alluded to that in the preview already. So regional wall strain is actually a novel parameter that can be derived from angio-derived physiology. Actually a 2D angio-derived physiological index that measures the difference between the diastolic and systolic diameters across a dynamic coronary angiogram. So also something that is readily available on site in routine practice. In this case, that was tested in non-culprit arteries of patients enrolled in the Target All-Comers trial. So remember, this was a stent trial performed in 2016, randomizing 1,500 patients to either Firehawk or Zymes. But the interesting part is this trial, obviously all the angios were available and there is 5-year clinical follow-up available. So the idea of this trial to assess whether non-culprit lesion, regional wall strain and angio-based physiology, MuFR in this case, were correlated to future adverse events. And what appeared in the primary outcome of the trial, that the event rates were significantly increased in those patients with a low MuFR, as you would expect, but also in patients with a regional wall strain above 13, which appeared to be a significant predictor of future adverse events. In absolute numbers, or actually relative numbers, so the risk for future event was increased with 60% in case the FFR was positive, which is something that you would expect, right? But from the regional wall strain perspective, the increase in event rates was about 230%. So the hazard ratio was 2.3 in lesions with a wall strain above 13%. So this identifies wall strain as a very promising, novel, readily available predictor for lesion failure in patients with intermediate lesions.
Well, you know, I think the concept of vulnerable plaque has a lot of attraction these days.
Absolutely.
Since prevent, it only got more. And the question is how to approach these vulnerable plaques, right? Is it you need to do an additional therapy invasively, or do you need to be more aggressive in terms of lipid-lowering therapies, PCSK9 and
Absolutely.
and so on? So this definitely will be research for the next couple of years.
Absolutely.
Yeah.
Good.
Doctors LM.
Doctors Left-Main, very briefly. So this is the next trial out of the doctors pipeline, again presented by Nicolas from France. 188 patients that were randomized to either OCT or angio-guided PCR for left-main stenting, with the primary endpoint being FFR. And we already predicted that this would become a difficult task, right? To prove that OCT-guided PCI would lead to a significantly higher post-PCI FFR as compared to angio-guided PCI, and that appeared indeed the case. Post-PCI FFR 0.89 in both arms, without any sign of difference between both arms. No difference in MACE was reported, but obviously in a trial with 188 patients, I would not draw too much attention to that.
So then the TCW trial. So Alvin Cady presented the TCW trial on the first day of the late breakers here in Paris. We already reviewed or previewed the trial. We were anticipating an underpowered study because the sample size was very small. The study was stopped early or prematurely because of slow enrollments. And so over a time period of 5 years, only 172 patients were enrolled, 91 patients for TAVI, 81 patients in the surgical arm. Eventually, in the intention to treat analysis, only 91 TAVI patients versus 77 surgery patients were compared. And so patients had to be at a higher operative risk, and they had to have coronary artery disease. The mean age of the patients was 76 years old. 2/3 were men. STS score was 3.5 and the Stintex score was only 13. So this was not extensive coronary artery disease. So I do believe that there has been already some kind of selection bias in terms of coronary disease. The primary endpoint was a composite of all-cause mortality, stroke, myocardial infarction, coronary or valve reintervention, and life-threatening or disabling bleeding at 1 year. The results were quite significant. There was a significant difference of the primary endpoint of 4% in the TAVI plus PCI arm versus 23% in the SAVR combined with CABG arm. And then the stroke and death rate was 1% versus 12.5%, where there was clear superiority in favor of TAVI plus FFR guided PCI. The results were quite astonishing. Death rate was 0 versus 7% at 1 year. You know, I think we are really talking about an underpowered study, so I would want to urge us not to overemphasize and overinterpret the data. But it is what it is, and I think it also is somewhat in line with the recently presented Dedicate trial at ACC, where the PCI, at least at TAVI, at least at 1 year, comes with a lower risk than surgery.
That's a fact, and as you say, I mean, it's a small trial, it may have been underpowered. Alvin's reaction was that actually the trial was halted early because of the excess amount of mortality in the surgical arm. 12 versus 0, you cannot deny the figures, but as you say, it's relatively small. We should not overreact, but luckily there is more on intermediate risk and patients with aortic disease.
Absolutely. There was also the SOLVE-TAVI trial, and that was a head-to-head comparison of the Evolute R platform versus SAPIEN 3. A German study, we already reported, or they already reported the 30-day outcome data in European Heart Journal. There is also a subgroup of a sub-analysis comparing conscious sedation versus general anesthesia. Let's just focus on this primary endpoint of death, stroke, more than mild PVL and pacemakers at 5 years, comparing Evolute with SAPIEN. Well, there was no difference whatsoever between the two treatment arms. The event rate was up to 68% in both treatment arms. If you only look at paravalvular leak, there was a little bit more paravalvular leak with Evolute. There was more patient prosthesis mismatch with SAPIEN, more pacemakers with Evolute. But then the remarkable observation was that the stroke rate seemed to be higher in the SAPIEN arm as compared to the Evolute arm. And that is intriguing, because how could we explain that? Well, one of the hypotheses is that there might be more leaflet thickening hyperattenuation and leaflet thickening and reduced leaflet motion with balloon expandable valves as compared with self-expanding valves. And there are some signals in the literature that make that suggestion. Well, if that is the case, that might be a potential explanation for an increased neurological event rate. That said, this trial was not powered for that endpoint, so it still can be a play of chance. So again, here, I would not overemphasize these results. I think at 5 years, no difference in clinical outcome between Evolute-TAVI or S3-TAVI.
Absolutely. 219 patients, a stroke risk of 3% per year. I've now 15%. I'm not sure how realistic that is, and I would definitely urge people not to overreact on these differences or potential differences in stroke.
Yeah. Another trial that was highly anticipated was Notion 2, the trial from Denmark. Ole de Bakker presented these 370 patients who were enrolled, mean age 71 years old, STS score of only 1.1, the lowest ever reported in a randomized study. And also important, more than a quarter of the patients had bicuspid aortic stenosis, as you would expect in a low-risk patient population at lower and who are also younger, obviously. The primary endpoint was a composite of death, stroke, and rehospitalization. No difference between the two treatment arms, 10% versus 7%. The stroke rate was somewhat higher with TAVI versus surgery, and that is different from all the other trials that have been recently presented. Pacemaker rates, as expected, somewhat higher in the TAVI arm, whereas patient prosthesis mismatch was more common in the surgical arm. The reintervention rate was low for both treatment strategies. KCCQ, no difference in quality of life between the two treatment strategies. And then there was this interesting hypothesis generating analysis again, separating the tricuspid patients or patients with tricuspid aortic stenosis and patients with bicuspid aortic stenosis. In the patients with tricuspid aortic stenosis, basically there was no difference whatsoever between the two treatment strategies, but in the bicuspid cohort, surgery seemed to outperform TAVI. In terms of, if you look at the primary composite endpoint, was 14% for the bicuspid TAVI versus 4% for the bicuspid surgery. If you then only look at death and stroke, it was 2.2% versus 1.5% in patients with tricuspid aortic stenosis, versus as compared to 6% versus 2% in patients with bicuspid aortic stenosis. So you might ask yourself, okay, are we seeing here a problem with TAVI in bicuspid aortic stenosis? I think we are overreacting again by making that claim. At least this is something that we look for. We need to dive into the data, get some more granular information. Was cerebral embolic protection applied? What kind of phenotypes were involved in this trial? But I don't see a signal up to date, but you know, this may help us also in the designing of future bicuspid aortic stenosis trials.
I think that's the critical comment. It raises discussion. This is a secondary endpoint of a subgroup analysis in a trial of merely 370 patients. So I would again not overemphasize, but again it urges the need for proper randomized trials in bicuspid to settle this issue, right?
And also when, you know, this is this statistical principle, you know, when your primary endpoint is negative, you always have to be very careful with sub-analyses and subgroups. So that is, I think, an important comment. We also had the landmark trial. Professor Serhuis presented this landmark trial, a randomized controlled study that was also published or is about to get published in the Lancet, where the Mieghem transcatheter heart valve is compared with the other commercially available SAPIEN and Evolute platform. An interesting, well-designed trial, if you will. More than 700 patients were randomized to either Mieghem or Evolute or SAPIEN valve. And so there were basically two cohorts, Mieghem versus SAPIEN and then Mieghem versus Evolute, and a 2-to-1 randomization. Well, long story short, there was no difference in the clinical endpoints between all the strategies, but if they looked into the comparison of the valve performance between the balloon expandable valves, so the SAPIEN versus the Mieghem seemed to outscore the SAPIEN valve. And if they compared the hemodynamic valve performance of the Evolute versus Mieghem, there was no difference.
No difference.
So that, again, creates a suggestion that, the Mieghem is a different balloon expandable platform than SAPIEN, so you cannot generalize. And it might have in hemodynamic advantage, but also that trial was not powered for that analysis. So I think this is becoming a theme of the meeting. We have a lot of interesting data, but most data are not fully powered to make solid conclusions.
Yeah, I agree, and I think there's little reason to believe that the MyValve would be better than the Sapien, except for one thing, and that's what also Patrick Royce mentioned, was the different sizing table, right? So there are more sizes with the MyValve that perhaps allow a more patient-tailored implantation, and that's a discussion I think that is plausible. I mean, the explanation is plausible, but there is thus far no data to support the clinical relevance of this sizing difference.
But also a good argument to go to the Lancet and dive into more granular data here.
Exactly. So finally, we'll end today with a short recap of the CALIPSO trial. CALIPSO addresses an interesting concept. So it's a trial designed to compare a OCT-guided stenting algorithm versus a angio-guided approach in patients with calcified disease. So as you know, a lot of debate on calcium algorithms. Specific types of calcium need specific types of treatment, and little, in my perspective, very little validation of any of these algorithms. But this at least is the first trial that actually addresses the question as to whether imaging changes your strategy in terms of calcium modification, and in a trial with the primary endpoint being minimal stent area. So that's a relevant endpoint in my perspective to see whether this actually positively influences final stent expansion, and that's actually what the authors were able to demonstrate with a dedicated OCT-guided lesion preparation algorithm in 140 patients that were randomized. The strategy to tackle the calcium was changed, and what was interesting in it, to dive a little bit into how it changed, what it basically meant, that the use of non-compliant balloons significantly decreased at the cost of an increased use of lithotripsy balloons. So a very low number of patients with atherectomy, not much mentioning about scoring or cutting balloons, but a significantly increased use of lithotripsy with the shockwave device, and that at the end resulted in a significantly larger minimal stent area in the OCT-guided arm, with a minimal stent area of 6.9 versus 5.3 in the angio-guided arm. So with that, a positive trial that I think opens the door to future research on the topic.
Well, but at the same time, the major takeaway for me at least is that it makes a lot of sense to treat or to approach these calcific lesions with imaging guidance.
Absolutely.
Because that will definitely give you an additional piece of information. Whether it is lithotripsy or atherectomy, we cannot comment based on these results, but I think this is definitely a step in the right direction. It is good to use imaging, invasive imaging, when you are treating calcific aortic coronary disease. With that, I think we are at the end of part one. Thank you very much for being with us today. We are one more day here in Paris, and then next week probably we will record part two of our review of the late-breaking trials of EuroPCR. Thank you very much.
Thank you. Bye-bye.